right, Dr. Holm, how are you today?
Good.
We're going to have some fun.
Good.
I have a bunch of questions for you.
Great. I'm glad to be here in this beautiful environment.
Great. We're going to start with an easy one. Tell me about your origin story with diving. What took you to diving? How did you become a diver?
Well, there's no one in my family that was a diver, but I lived in a neighborhood in Los Angeles, not too far from the beach and where you could beach dive. And one of my neighbors, when I was 12 years old, his uncle would take us on dive trips, beach dives, primarily to San Diego and things, and we would watch it. But I couldn't get in a scuba class until I was 13. And so then I took a junior scuba certification with my dad. And he never dove again. He hated diving, and I haven't stopped since 1969.
That's fantastic. That's fantastic. Okay, so then tell me your origin story about becoming a doctor. What drew you to medicine?
I think I was like many people in my time that dove, wanted to be a marine biologist. So I went to University of California in Santa Barbara, which is right on the water, and I became an instructor and taught scuba diving to make a little money on the side, but I was marine biology, but realized I didn't really like marine biology. I was more interested in some basic science things and a little more math, physics, physiology, and then I realized that marine biology was not for me, and I started to become interested in medical school. And I don't have anyone in my family that's a doctor, but I got interested in medicine and then applied to medical school.
Okay, so what was your specialty when you started medical school?
When you start medical school, you do general. So I went to Georgetown Medical School in Washington, D.C., and I had applied but not gotten in, so I had an extra year. I reapplied. During that time, I was a dive master in Grand Cayman. So I got to have my fun and be a dive master, and then I got accepted to medical school. So I was in Cayman Islands for about a year and a half, and then I went to Washington, D.C. to Georgetown. And I liked I really thrived and loved medicine, and I do to this day. And then you kind of have to decide your third and fourth year what specialty you want to go into.
And so what was your specialty that you then chose?
I went to Northwestern for an internal medicine and emergency medicine residency. So it's a combined residency. So I'm board certified in internal medicine and emergency medicine. And I was still diving at that time during my residency and after, but I was working in the ER primarily. And that would give me time off to go on trips. And then I came to a DAN course and got involved in diving medicine as a participant. In fact, before I went to med school, Dan, when Peter Bennett was putting on the courses way back, when he came to the Cayman Islands, and he had a distinguished faculty, and I was the dive master when I worked in the Cayman Islands. So I was the one hauling the doctor's tanks and filling it, but he let me come to the lectures. And that was another thing that got me excited in diving medicine that I eventually came back around to, and then got a specialty certification in undersea and hyperbaric medicine in 2000.
Okay.
So I had 3 board certifications of internal medicine, emergency medicine, and undersea and hyperbaric medicine. But my love is obviously the last.
Yeah, of course. So for those of us, tell us more, internal medicine. What is included in internal medicine?
Internal medicine is sort of like a general practice. It's generally a 3-year residency, but you don't generally do like family medicine, you don't do pediatrics, you don't do obstetrics, those kind of things where you're delivering babies. So internal medicine really focuses on diseases and internal structures. And most specialists, like a cardiologist or a gastroenterologist that do your colonoscopies and things, they all train as internal medicine first, and then they go on to those specialties. So that's internal medicine.
And then when you said you went into hyperbarics, give us high level, what is hyperbarics?
Hyperbaric medicine, well, undersea and hyperbaric medicine kind of a combination, and sometimes they don't overlap, sometimes they do. But hyperbaric medicine is providing care for patients in a hyperbaric chamber, a pressurized chamber in which you breathe oxygen. And we always think of divers that get the bends or gas embolism as our only patients, but we treat other conditions, wounds from diabetics that don't heal, people who've had cancer and the radiation damaged tissue later doesn't heal, and we can help with those things. So we treat other conditions. So hyperbaric medicine is sort of a treatment of various conditions, including diving disorders, in a pressurized chamber, and it's quite effective for most of these conditions.
Okay, and so then you worked for many years where?
So for the last 25 years, I've been involved in hyperbaric medicine. I was still doing some emergency medicine on the side, but I was always involved in 24/7 hyperbaric facilities throughout the western United States. I've been to several places, but they've always been at places that can take and treat divers. So it's 24-hour call. All the places I worked were able to treat patients that were very sick, including divers, if they're on ventilators or intravenous solutions or things like that. So for 25 years, I've been doing 24-hour, 7-day-a-week hyperbaric medicine. Now I have partners to help cover for call, but they have always been at kind of level 1 top-notch facilities.
Okay, so a diver comes in. Well, let's start with how many divers would you see in a year versus other hyperbaric uses of the hyperbaric chamber?
That's a good question. I'll give you an example from Virginia Mason Medical Center in Seattle. And I'm no longer the medical director there, and as in my semi-retirement years here. But give you an idea, we treat about 20 to 30 decompression sickness cases a year, which is one of the busiest centers. Many are recreational divers. Some are recreational divers. In Seattle, there's a lot of recreational diving, a lot of technical diving, but we also treat commercial divers, public safety divers like police and fire dive teams, and also there's harvesters. Gooey duck clams are harvested in the Pacific Northwest, and Native American tribes and commercial companies will harvest these clams, and they get the bends and gas embolism in addition to recreational. So they commonly don't use DAN or don't call DAN often, but about half of my cases of diving accidents that need to go in the chamber are recreational, and about half are not, and that's about 30 a year. It's going down, fortunately, due to diving safety and the work of DAN.
All right, so a diver comes to your facility and they're presenting with what kind of symptoms would make you think they need time in the chamber?
So generally the way it works is there's so few chambers in the United States, unfortunately, that treat divers that we get, for example, in Seattle, we cover divers that get the bends or gas embolism from all of Alaska down to Northern California. So generally the way it works is they may call DAN, they will generally recommend going to the closest facility, and usually the closest emergency department, to see, is that really a diving emergency? Because you could have arm pain, numbness, tingling. That could be a heart attack with arm pain, or it could be decompression illness. So they usually get evaluated there, and sometimes they'll come directly to us, sometimes they'll be referred by DAN, sometimes they call us directly, and then we transfer them to our facility if they're not already there. Sometimes we bypass other centers if we know it's decompression related, and they'll come directly to us. Then they go to the emergency department, we evaluate them. But over half the calls I get at night on call may be diving related but not need a hyperbaric chamber. Like somebody has some ear clearing problems, or they have some issues that don't need the hyperbaric chamber, but most doctors have no knowledge of undersea and diving and hyperbaric medicine. They're not trained, and that's the value of our courses here. We have doctors that are maybe just divers. They're not practicing at a chamber or a clinic that treats divers, but they don't know much about diving medicine, because in medical school you get 0 basically, and residency, if you're lucky in emergency medicine, you may get taught 2 or 3 lectures. And so what we do is those doctors will generally call us for advice, and then we encourage them to go to these courses, these medical education courses, so they really have a higher knowledge of ability to know where to direct patients. They not have a chamber, they may not have a practice that can treat divers, but they know, yeah, this is something that needs to be referred. Fortunately, Dan does a lot of that beforehand and knows where to send people through their referral network.
So if a doctor is interested in these courses, talk a little bit about what this course is, and do you need to be a hyperbaric doctor to come, and who would be invited, and what's the course all about?
Yeah, these are generally week-long courses, run several times a year, co-sponsored by DAN, Divers Alert Network, and the Undersea and Hyperbaric Medical Society, which I was the president of. And we have these courses that generally have about 4 faculty. They're about a week long. They have 6 days of educational opportunity with 4 hours a day of lectures. And we bring in experts from around the world for these courses. We want the best of the best. Dan and UHMS does not sacrifice on just someone, a doctor that wants to show their pictures and talk about something. They really need to be, the faculty need to be top notch. The audience, though, can be anyone. Typically, these are people that are passionate about diving. And if they're divers, say in Kansas, and they're a doctor, divers will find them. And they will ask them, and many times they don't know what to say. The best answer is probably call Dan again and get information, get directed. But they will raise their level of education. So you don't have to be a hyperbaric or undersea or diving doctor. You could be any specialty. You don't even have to be a doctor. You could be a nurse practitioner. You could be a physician's assistant. You could be an RN. You could be an EMT. And even DMTs, diving medical technologists, we've had here. It's generally focused more towards providers, nurse practitioners, NPs, and DOs, MDs, those sort of people.
Who is invited to these classes? What kind of doctors are invited?
Generally, our audience can be anyone, and they may be from any country, but we also open up this course to local hyperbaric or diving providers, including doctors, nurses, technicians, and we invite them to attend some or all of our classes. And here, Dr. Melville and his staff from the St. Lucia Chamber came over to our course. So we do that to kind of raise the bar at all these locations. So it's not just for the providers and doctors in the United States or other countries. It's for the local community medical people that are taking care of all these divers.
Wonderful. Talk about why did you choose to do this course in St. Lucia?
I've been to St. Lucia, I think, 4 or 5 other times. And it's a beautiful location. This resort is beautiful. We know the dive operation. We always go to places that we're familiar with. We try new places, but we have a staff like yourself and others at Dan that find the best place. Because we want a safe environment for our doctors as well, because they're just divers like anyone else, and some are new divers. And they bring their significant others or friends or family, and they may go diving with us, not be involved in the academic component. But this resort has it all. You can see by the backdrop, the location, the diving is beautiful. So we go to different parts of the world, and we try to find resorts that fit the needs for the people that are coming to our courses.
Right, so this week they're able to get 26 credit hours and could do up to 14 dives, so there's some fun built into it as well.
Yes, there's lots of fun. The schedule is packed. I always say, even as faculty, if I do a week here, I need a week vacation to recover. But as participants, they have a little more flexibility. They usually and almost always attend every lecture, but not always, but they don't get credit if they don't. And they enjoy the resort, and their family members may come and enjoy the resorts as well. But they can get continuing medical education that is approved and generally valid for their certifications and their licenses and the requirements. What better way to get educational credits than a location like this and diving? But we want to make sure that courses are high quality.
Right, so we're here at Anse Chastanet in St. Lucia, and of course you see the beautiful view. So tell me, what was the coolest thing you saw diving this week?
I saw a turtle on our last dive. I love turtles. We've seen a lot of small things. We've seen a lot of almost anything other than big pelagic. Not a lot of sharks here, right, which may be good for some people, but not bad and good for others. But we see your typical type Caribbean diving. St. Lucia is well known for giant barrel sponges. Yes. It's one of the sponge capitals of the Caribbean. And the resort, this is the food, the restaurants, the entertainment. There's a lot going on that you can participate and not participate. There's evening programs. We have evening lectures. There's receptions. There's plenty of fun.
Plenty of fun.
Yes.
I get asked a lot. A diver hears about hyperbaric medicine, hears about they might have to go to the chamber if they get the bends. What would the experience be for a diver going into a chamber? What is the experience?
Typically, if a diver gets decompression sickness, let's say, they may go to a facility like an emergency department. Sometimes they'll go directly to a chamber, but we don't have all the blood tests and the x-ray machines and the laboratories and things at the chamber itself. So we many times will go to the emergency department, be evaluated, give oxygen, provide care, intravenously if we need any x-rays or imaging or it's not clear whether they have the bends, but let's assume they have the bends. We'll then see them, and then they'll go to the hyperbaric chamber. That can be anywhere from a clear, small, single-person chamber, which can treat the bends as well, to a large chamber. For example, the one in Seattle that we have is 50 feet long and 10 feet in diameter. It's like the size of a 737 fuselage. We generally have them in a big reclining chair or a gurney if they have to lie down, and they get oxygen. They pressurize the chamber with air, most of the multi-place chambers, so you have to clear your ears. But most divers know how to clear their ears. And if they were able to dive and get the bends, they did clear their ears because they wouldn't be able to go down. So they clear their ears for that first 5 minutes or so, and then they're breathing pure oxygen through a hood, which is like a clear, looks like a space hood, or a mask on their face, and they breathe oxygen. We don't fill the entire large chambers with oxygen because of fire safety reasons. And they're in with another staff member in the multi-place chambers. So generally our divers, if they're not critically ill, love to talk about diving. Imagine that. And they talk to our nurses or our technicians who are inside, and the doctors are outside with the operations person controlling the chamber. And if I need to get in, or I need medical supplies, or the diver needs to get out, we have extra chambers attached to that called locks that we can put people in and out of. So the rest of the time, some have little TVs on the outside or inside that are fire, that are safe. Some, we give them magazines. Some people, they just have to chat or sleep. But we wake them up to check their neurologic status. And we are able to provide monitoring, intravenous's, all the way up to ventilation on someone on a respirator if need be.
So can I take my iPad in with me to watch a movie?
Sadly, you can't. Fire safety is a problem. Oxygen itself is not flammable, but in a controlled setting, in a confined space like an airplane, first off, we can get you out. The airplane you can't necessarily, but you're in a confined space, so fire hazard is a big risk. So anything goes in the chamber, including we have them take off their street clothes and put either gowns or scrubs on. But we don't want anything in there that could potentially put the patient and our staff at risk. So we don't want to make the diver worse than when they came in. So we are very strict about what can and can't go in. So unfortunately, you cannot take your iPad or iPhone or Android, but sometimes that's a nice relief. That may be the only time, other than when they're sleeping, that they're not tied to their electronics. And the treatments can be anywhere between 4 to 8 hours, sometimes longer.
So let's go into that. We hear people talk about a table 6. What is a table 6? What does that mean to you?
A table 6 is a treatment protocol that was developed by the Navy in 1967. And what it is very standard and considered the gold standard worldwide. And there's a number of treatment tables, and various countries and places, even within the United States, will use different tables, but the gold standard is the table 6. And that's where we compress them down to 60 feet and put them on oxygen, and then later they go up to 30 feet on oxygen. We decrease the pressure. There's no water in there. The chamber's not going down or up or anything else. And some people say, you can't breathe oxygen at 60 feet. You would never do that in the water. For those nitrox or technical divers know that. But we're in a dry, safe environment. So the side effects of oxygen toxicity, which are very rare, are not a problem. So it's generally a 4 to 8 hour treatment, and it's kind of the gold standard. We have the ability to alter it. If people are sick and need more treatment, we can go longer. We rarely go shorter, but there are some protocols that use treatments as low as 2 hours. So those can also be used, depending on the severity and what resources you have.
Different chambers would be different, but typically how many doctors and nurses or medics are required to do a chamber dive?
For a multi-place chamber, we generally require at least 4. At my facility in Seattle, we have an inside attendant. That's either a nurse or technician that's trained that goes with the patient, so they're always there. There's never alone in the chamber, in the multi-place. We have a person driving the chamber called chamber operator. We have a charge nurse, who is basically my boss. The charge nurse controls everything, and we have a doctor. That's the team. So it takes 4 people to treat a single diver in a multi-place chamber as a minimum.
Talk to me about some of the topics specifically that you were covering this week, some of the things that you were talking about.
So this week, we covered various things. We had another faculty talk about ear and sinus barotrauma and ear clearing issues and ear problems, because that's the most common diving malady that we will deal with is ear problems. We get the most phone calls regarding ear-related problems. We talk about lung-related problems. We talk about what things you can dive with, certain medical conditions. Can I dive? Is it safe to dive with that medical condition? We cover that. And more, my lectures were focused towards other conditions such as immersion pulmonary edema, a condition in which people's lungs can fill up with fluid. It's rare, but it's different from decompression sickness. It does not require going in the chamber. I also have a talk on all these types of chambers. How can you treat people in the chambers? I also talked about what are these treatment tables, like the table 6 or other treatment tables. What's the data for it? And most of our lectures, including mine, will have heavy references and up-to-date information, because things change all the time. So the topics will vary on the courses and the faculty, but we generally cover at these medical education courses a core curriculum that we want to make sure they leave, by the time they leave, they have a basic information, and then a lot of other specialty stuff, because people have their special interests, their special research, their special talents. We talk about technical diving, commercial type diving. So a broad spectrum of material and topics, but a core curriculum.
So you mentioned immersion pulmonary edema. That's been in the news quite a bit lately. So talk about what that is and why it's rare, but why we're still concerned about it.
Well, immersion pulmonary edema has different names, but it can occur in swimmers or divers, but it does require immersion in the water. So what happens when you go in the water is, ordinarily when you're outside of the water, blood is pooling in your legs, or dependent on gravity. But when you go in the water, you no longer have gravity pulling that blood down to your legs. So it tends to go into the chest, and the heart can pump that extra blood volume, but sometimes it backs up. And if it backs up, it gets fluid on the lungs. Other things that affect immersion pulmonary edema, or that can contribute to it, are water temperature. Sometimes we dive in cold water, or you're cold even in warm water. If you're stressed, anxious, if you're exercising, that's a risk factor. And we're also finding that some people are more susceptible. The older people are more susceptible than younger people. It tends to. People with hypertension or pre-existing cardiac conditions may be at risk. Tends to be a little more seen in females than males, but not always. And it's fairly rare, but the treatment is pretty standard treatment, but doctors need to know what it is and diagnose it and not mix it up with the bends or gas embolism. So they do not require going in the chamber, but they require good medical care. And then it can recur, and in rare cases be fatal. So there are ways to decrease that risk by altering those risk factors that I talked about.
Okay. One of the talks, many times our evening talks are a little more special interest type of talks. And this week you talked to us about taking a turtle in a chamber. You want to give us a quick rundown of what that was about?
Yes, I got called by the Seattle Aquarium in 2016, and they had a olive ridley turtle that was about 3 or 4 feet long, a large turtle, sea turtle, that had become stranded on the coast of Oregon. And it was very cold. They warmed the turtle up. It was nearly dead. The aquarium in their rescue center recovered the turtle, but it had a buoyancy problem. It floats too much. Turtles can get the bends. Tucker did not, name of the turtle, did not have the bends, but he had another condition that had gas involved. And the veterinarian called me from the Seattle Aquarium and said, can you put Tucker in the chamber? And so we brought Tucker over, and I got approval from the hospital, and we did not put Tucker in with other patients or divers or anything. And we volunteered our time, and the veterinary staff came over. The veterinarian and myself were inside with the nurse, and then there was veterinarian technicians, another hyperbaric physician on the outside. And actually we had to put a breathing tube in because turtles can hold their breath, and we're changing depth and pressure even in the chamber. We didn't want to give the turtle an embolism. And we did. Tucker was in the chamber for about 4 or 5 hours. Did well, was eventually sent to SeaWorld for rehab, and was released. We may have contributed to that. We may not have helped, but it was a big fun time for all, and Tucker did well.
That's fantastic. So you talked about when you first came to dive medicine, you had seen some DAN courses years ago. For you as a diver, how did you see Dan's mission working for you as a diver?
Well, as a diver back in the old days, I was familiar with Dan in this very early days. And so I've seen Dan evolve to what it is today, which is a great organization. It's not just the insurance component or membership that has some benefits, but I say you need to have some sort of dive insurance. Dan is the one that I happen to have, and membership that comes with some amount of insurance. There's travel insurance that's separate and things like that. But the most important thing that Dan provided to me, my students, and the people I was working with is that they could call, whether they're members or not, to their hotline and get medical advice. It doesn't have to be, I'm bent, I need a chamber, but they will help coordinate that for you. They don't provide the medical care, but they'll give you the right direction, because some chambers may be closed, not available, or you may not need a chamber. And they also have an advice line, an alert diver, and a great online presence. That it's a wealth of resource. So you want to know about some condition, if it's not on the Dan website, you let us know, or them know. I'm not an employee of Dan, and it will be on there. So it's a wealth of information, one-stop shopping, and it's vetted by experts. It's not the problem with, you go to bulletin boards and chat rooms and things and various things. You'll hear a lot of information that's probably misinformation, so this is kind of, if you want to get I think the state of the art, you go to Dan. So Dan's been important. Dan was important to me. I was on a dive trip and got injured, not with decompression sickness, but injured, and Dan was able to help me as well. And I've also been in remote locations and asked by Dan to see patients in remote locations. So it's invaluable. I really couldn't imagine the diving community as it is being this safe without an organization like Dan.
Fantastic. So you've been the co-director for this continuing medical education class for a little while.
Yeah.
What's next?
Well, I'm now just emeritus physician, so I'm not working full-time anymore. So I'll hope to continue providing as faculty or director or as a participant in these courses. And then if I'm not on these courses, and it's not other educational things I do as well, I'm diving or sailing or enjoying life after the grind of 40 years of medicine. So I'm going to my 40th med school reunion coming up at Georgetown, and so this is a time in your life where you want to enjoy it, and a lot of older divers are enjoying it, and Dan really is a safety net, because we've got the money, we may have the time to do all these trips, but we're not 20 anymore, and I don't dive like I'm 20 anymore. I dive conservatively, and so it's important to have that safety net. And so my goal is to keep doing this as long as I can. When it's not safe, I'll hang up my fins.
Do we have another couple of courses planned? Where are we headed next, beyond beautiful St. Lucia?
Well, we're coming up this fall. We're going to Bonaire, and we've been there before. Clear water, warm, generally no hurricanes generally. We've been to Bonaire. We're going to go to Fiji. We did a course last year in Fiji. And then we're looking all over the Caribbean and the world. We've been to the Philippines. We've been all through the Caribbean. Previous courses, Generations courses have been in Hawaii and places like that. So we look all over. We generally pick places that have good, safe diving with generally warm water. And liveaboards are a little challenging, so we haven't done medical education opportunities on liveaboards. But you name it in the part of the world, we've probably been there, but we're trying to get a little more international presence with our medical education. And our faculty is quite diverse. We have them come from all over the world.
What research topic are you interested in looking at next or learning more about?
Well, I'm always interested in learning about new technology in diving and how that affects us physiologically. We have rebreathers, we have all kinds of new diving systems and new breathing gases, new computers, and I have an interest in but don't do research in those things. When I was in practice, most of my publications were in either some diving related things, but primarily in carbon monoxide poisoning, which we treat in the hyperbaric chamber with severe cases, and trying to prevent carbon monoxide accidents, carbon monoxide poisoning. And that I mentioned the people who've had cancer and been cured of their cancer, but they had radiation to treat it, and years later they have problems with their bowel, bladder, jaw, other structures, and we help that, and I published articles on that as well. Now that I'm not in that academic arena, my interests are more on education and more diving-related maladies, as well as publication on that.
So we were talking about what the experience is for a diver in a chamber. What happens if I'm in there and the electricity goes out?
That's a good question. Pretty much all chambers, I can't speak for all chambers since I've not seen them, but have backup systems. So you have compressors, and really people don't realize, but the chamber is a low pressure system relative. We have our tanks that are 3,000 pounds per square inch. The chambers are not going much above 50, to even if we use a deep 100 pounds per square inch. It's low pressure gas, but it's a large amount of gas in these big chambers. So we have multiple compressors that fill up these tanks first, and then if those compressors go out, we have backup systems, but you've got enough gas in these storage cylinders to run a multi-place chamber for a table 6 or longer. The breathing gases are commonly come from high pressure cylinders, so they're just like giant scuba tanks with oxygen or air, whatever you're breathing in the chamber. So we have backup for everything. We have fire suppression, sprinklers, a requirement. There's very strict safety standards. And Dan has been a leader, and Francois Berman has been a leader in hyperbaric chamber safety, because you can Google it and you've seen on the news some untoward incidents. Usually these are at freestanding facilities, but there's been fires and things and other accidents. But these are extremely rare, if not just extremely rare in these chambers. And Dan helps to make sure the chambers are up to snuff. And it's not just a chamber. You need a staff that knows how to treat divers and how to take care of the chamber and maintain it. So I think, yeah, if power goes out, you're still safe. But if a chamber is down, that is not available to take it, or there's another diver, then JoAnn or the local community will direct to the next closest facility. And that's very valuable, because you don't want to fly or helicopter or somebody in or take them by ambulance all the way to chamber and it's not available. So Dr. Nichado has a database that's amazing. He can tell every chamber what level of capability that in Dan headquarters, the 3 Dan headquarters that deal with the hotline. And they know what chamber is online, what's not, what they're able to handle, where to send them. If that chamber is not available, we save the patient having to be transferred there and then transferred to another facility.
You had said that a lot of the chambers in the United States don't accept divers. Why wouldn't they accept divers?
Many of the chambers are treating these other non-diving related conditions, such as diabetic wounds. So they're typically small chambers which can provide adequate oxygen to treat a diver, but they're generally in wound clinics, which are usually outpatient facilities. So they're not close to the ER, they're not in the hospital, and they don't have to be in the hospital, but they're not set up for that. They're 9 to 5, 5 days a week. And divers don't just dive 9 to 5, at least they don't present with their symptoms. Yeah, they may be treated after hours. So there's lots of chambers, but the people are not trained in it. They may not be open. And so, but they are doing a useful purpose to treat these other conditions. But we want to make sure we need to know which chambers have the ability to treat divers. So you don't want to just Google hyperbaric chamber if you think you have the bends and drive or even call. They will commonly tell you if you call, we don't treat divers, please go here or there. And I mentioned how many we treat from Alaska all the way down to Northern California, but there's chambers all over. In Seattle area, there's probably 10 chambers within 20 miles,
okay,
but only one that treats divers.
Well, Dr. Holm, I appreciate your time today. This has been very enlightening, and you are always fun to listen to, as well as have all the research and the science behind it. So thank you for your time.
Thank you, and a pleasure to be here.
Thank you.